fitness bit. So I run dissection classes for manual therapists. That's kind of my shtick. I've also been something called the Bowen technique I introduced to Europe in the early 90s, written a couple of books about it. And what got me interested in doing what I currently do is that my feeling about anatomy is that it doesn't really cover what we do as therapists, what we do as physios or chiropractors, osteopaths, massage therapists. We learn names of things and we apply those names. And when you name something, by nature, you tend to separate it. So, for example, we talk about the iliotibial band. And actually, you know, whenever you open up a body, the big shock for everybody is there is no iliotibial band. It doesn't exist. It's not a thing. You have to make an iliotibial band in much the same way as you have to carve out a swan from a block of ice to make it look like a swan. There isn't a swan in the ice. I mean, you might say there is. So there are no things that exist independent of themselves. And our tendency, once we've named things, is to then assign problems to them. So now, because we think in a book, we see there's an iliotibial band, we say that there's potential for there to be an iliotibial band syndrome. Now, I'm not quite sure what that is, but I'm sure there's tools and rollers and therapies and courses that you can go on, provided that will show you that. But actually, if it's not a thing, then the premise that we have is flawed. Yeah. So the same thing goes when we look at things like the glutes and hamstrings. So I just wanted to quickly present to you a little paper today that was done in 2015 that I missed, and it passed me by because I had my own agenda to follow. So the gluteus maximus, can't quite see that, that's okay. Gluteus maximus is the largest muscle in the body, but actually for a large muscle, it only has one nerve of innervation, which is the inferior gluteal nerve. Has a wide functional range, and we talk about firing of glutes, and again, it's one of those things that's a little bit misunderstood, and I want to give you an understanding of what those. These guys do an amazing job, you know. So anywhere you go, it's the people like this that are the oils in the machine. So always, you know, look after your techs. Thank you very much. He just touched me. I don't even know his name. Is he going to call me? Is he going to text me? By the way, it's the end of the day. I'm not going to give you death by PowerPoint, right? So it's going to be fairly straightforward. I don't take myself too seriously, so you don't have to. There's a bar with a free drink at 5:30. I know we're all really looking forward to that, and that's the reason that you stayed, to get your free drink. I'm flattered that you filled your last half an hour before you got your drink. Somebody's nodding there. Thank you for the affirmation of that. That was self-deprecation, and you're supposed to do that. Never mind. So just relax. I won't bore you too much. And I'm always surprised when the next slide comes up. What's that going to say? Oh, yeah, so when you think of the glutes as being like a dimmer switch, and we'll talk about that when we come to the simplicity of the on-off idea, that there isn't really an on for a glute or an off for a glute, but there's a whole range in between on and off, and I want to look at that. Same thing for the hamstrings. The hamstrings injuries are the most common sporting injury. They are phenomenally common, and they are also recurring, as are all sporting injuries. So it's something like English Institute of Sport have estimated that something like 85% of all sports injuries are repeat injuries. It kind of cooks your noodle when you think of it, because it's a little bit like falls for elderly people. The biggest risk of you falling is the fact you've already fallen. So if you've already had a fall, your risk of falling is increased. Same thing if you're off long-term sick. The biggest risk for you being off long-term sick is that you've already been off long-term sick. So these are the way that we can manage statistics to try and work out who's at most risk. But if you have a hamstring injury, the chances are that it's going to come back. The outcomes of recovery are poor. They're notoriously poor. And probably the reason being is because we think of the hamstrings as a structure, which it kind of isn't, you know, so I want to talk about that. There's non-specific pathology. In fact, the hamstrings are a colloquial term. They're not really an anatomical term. The idea of hamstrings is a colloquial term for a collection of the groupings that we call biceps femoris, semitendinosus, semimembranosus, and for some reason the adductor magnus got left out, and I always feel a bit sorry for adductor magnus for being left out. Sorry, that. But because I think you should think of adductor magnus when you're doing the hamstring, much the same way as we think of the tech when we're at these things. We think of adductor magnus as being a forgotten hamstring. The hamstrings are just blamed for everything. Oh, I had a bad game because my hamstrings were bad. I didn't take the rubbish out because I had tight hamstrings. So hamstrings have been blamed for pretty much everything. Global warming, hamstrings. Oh yeah, when Robbie left Take That because of his bad hamstrings. Donald Trump, that's hamstrings, definitely. Brexit, definitely. You can't even see my slide there, but definitely Brexit is the fault of the hamstrings. So we might want to look a little bit wider at why we have these problems. And again, if our outcomes are poor and our treatments keep coming back, which they do traditionally, our data tells us this, well, maybe it's time to think about, maybe we've got it wrong in terms of how we think about things. And this is where traditional anatomy kind of slips up a little bit, and it's why I'm trying to teach the classes that I'm teaching, because I don't want to bring therapists into a dissection lab and teach them anatomy, which is the naming of parts to then study those parts to pass an exam. Who's done that before? You know, that's the nerve of innervation, and that's the biceps femoris, and you forget it, right? But actually, you are working on the body. And if you're doing your therapy on anatomy, the chances are you're missing out what it is you're trying to do. So I bring people into a lab to go, look, forget the names of things. Where does that thing stop? Is there an origin? Is there an insertion? Or is there a continuity? Is that a reference point that you have at the bone rather than it necessarily being a stopping point? If it's a reference point, where's it going from there? So once we start to label things and we start to name things, we're in trouble, you know, and especially if we're doing practice on them. So traditional anatomy as far as the hamstring muscles are concerned, there we go, put that up there. Biceps femoris, semitendinosus, semimembranosus, and you'll get told its attachment is at the ischial tuberosity of the pelvis. There it is up in there, you can feel it there. All right, and then we have gluteus maximus, again, is our traditional anatomy. The gluteus medius, gluteus maximus, gluteus minimus, and piriformis. Everybody knows about piriformis. We've got a syndrome for that, piriformis syndrome. Yes! Yeah, but it's selective. Why is it selective? Because we say, oh, well, the sciatic nerve goes through piriformis, so it must be the cause of your problem. Well, that's all very well and good, but what's this here? What are these structures in here? Anybody want to win a prize? There isn't a prize, but quadratus femoris, and this is obturator internus. It's one they catch you out in the exams because it goes round inside. It starts on the outside of the femur, goes inside. And these are the fabulous Gemelli brothers, Gemelli superiori, Gemelli inferiori. And they kind of sit outside guarding obturator internus. And an obturator internus is just absolutely beautiful. If you cut this off, as you would have done if you were a surgeon doing a hip replacement, you flip that off, and you fold it back, you have the most beautiful fish belly, sliding fish belly, where you see the tendons of obturator internus slipping themselves around and forming a covering of the obturator internus. But nobody talks about that. No, it's all piriformis, because we've got a syndrome for that now. So there's hamstring. I think we can move that forward to that one. There's hamstring, and there's gluteus maximus, or the gluteal collection. But we don't seem to think of them collectively. But actually, there's a lot more complication than that. So if I then showed you this is much more the arrangement of the glutes and the hamstrings than anything else. It's sticky. There is a tray of cinnamon buns. So if you tried to separate, don't judge me. Don't. I just stop eating when I hate myself. That's just how it works, you know. But if you tried to separate that one cinnamon bun from another cinnamon bun from another cinnamon bun from another cinnamon bun, then that's how it works. So our lesson for today is that the body is like a tray of cinnamon buns. Put that on your CPD. What did you learn today? Again, traditional view, this is anatomy trains. I want to state clearly here now that I consider Tom Myers to be a genius and anatomy trains to be a work of absolute importance, and I think it's one of the most important physical therapy books that there are on, and I wouldn't be here without Tom. I consider a friend and a colleague. Is this cutting in and out? Can you hear me? It's cutting in and out. It is. Okay. Do you hear that? It's cutting now. Anyway, so and I think anatomy trainings is a great way, but there's a very, very important word that gets missed when we talk about anatomy trains, and that is the word that Tom writes in the book, which is our imaginary lines of strain. And the word imaginary is very, very important. These lines do not exist. There are no line strain, fascial strain in the body. Fascia is not in a line. The whole point of fascia is that it's a container into which the muscle goes. In fact, I'm getting lost on here. It's cutting in. There isn't really a thing called fascia as such. There is epimysium, perimysium, endomysium that are all collagenous based and that all form the scaffolding. Shall I go on to this? That all, hear me now, situation, that all form the scaffolding of muscles. So if you have a cup of coffee, that's your fascia, and the coffee is the muscle. It's a container. So there isn't really a thing called fascia, and the direction of fascia is not unidirectional. It is multidirectional every single time that you ever look at it. So if the iliotibial band doesn't exist, what is it? It's a sheet of 360-degree tissue that wraps itself around the leg and with a thickened edge to it. You have to cut away the rest of it and leave that thickened edge behind, and then you've got your iliotibial band. So when we start to look at this is a great idea to think about the body as a whole unit. But that doesn't mean to say that it's anatomically possible, anatomically correct, or that they exist. You can cut them out of the body. I can cut anything out of a body. I'll just lie you down on the floor, I'll cut a unicorn out of the body, and we'll all have the school of unicorn fascia release. Don't get me started, it's probably happening. Instead, and this is where I was focused on. So this is what this is to orientate you. This is the long head of biceps femoris. This is the sacrotuberous ligament. And like in the previous slide, the superficial back line jumps along the sacrotuberous ligament and into the sacrum and then goes up the erector spinae as part of its journey. And this is where the sacrotuberous ligament goes. I did a dissection with Tom in 2007 at St. George's, and we had a chat about that. But it did appear in the second edition, so that's right. This is the sciatic nerve. So, and then if I just go on to the next slide, what you'll see is that this is that section lifted up. And so what I've always considered is there to be like a bursa-like structure. This is bone in here, and then this is this thickened tendon. But can you see how it's circular? It's almost like a joint capsule. It's almost like a disc in a spine. And we see this every single time. And we can start to see that there are transverse fibers that go across this. So there are clear transverse fibers giving any basically intelligent person the idea that this is not a line going up. I missed that for years, and I still kept on going, oh, look, I can join the hamstrings up to the sacrotuberous ligament. And completely missed the idea that actually there were transverse fibers that were going across this way, across the head of the hamstrings, but I had no idea what they went. Until 2015, when the Fascia Congress, there was a presentation by some Spaniards, and they presented this. And this appears, you can search for it online, it's a text available, and it's an anatomical and histological study of the structures surrounding the proximal attachment of the hamstring muscles. I know it sounds dull, but you've got to sort of dig deeper, and these guys in Spain did this. Now remember, when you have anatomists that they're not really looking at implications, they're looking at describing a sort of a structure, if you like. But this was in manual therapy, so they did a histological study, and they did 48 cadaveric dissections. So they're not mucking about with this. And what they discovered was much the same that I then discovered once I read this, that yes, actually the hamstrings that do not stop at the ischial tuberosity, but actually it's a tree-like structure. So I'm going to try and describe this to you a little bit. And this is a picture from their the reference and the credit for this is in there. This is their picture from their paper. As I said, it is available. And this is a transverse cut. So what you're looking at is this way. Yeah, it's cut this way. Transverse. So you're looking down. It's a bit hard to orientate yourself if you're not used to looking at. Here's the femur. This is the ischial tuberosity, and this is the proximal attachment, the hamstring muscle. So this is the hamstring muscle. And what you can see coming along here is this is the gluteus maximus. This is the sciatic nerve. And can you see how this is the gluteus maximus, and what you're seeing is this compartment, and there is a continuity. So what we're saying is that there is a continuity of the anterior fascia. Now, there isn't a huge amount of deep fascia on the back edge of the posterior portion of the gluteus maximus. It does vary. But on the anterior portion, there's a capsule, there's a pocket. And then coming transverse to this, there are fibers that run transverse. And they've called it, what I'm calling it, which is an ischial retinaculum. So the glute is pinned down but mobile on the hamstrings, and the transference of force and loading is through the hamstrings and into the glute, and then also into the sacrotuberous ligament. So there isn't a direct line of strain or force, but there's a distributed line. This makes a lot of sense. There's no straight lines in nature, and the reason there's no straight lines in nature is because the moment you load a straight line, you'll dislocate it. If there was any straight lines in the skeleton, the moment you loaded, say, the hips, boom, you dislocate it. And the same thing goes for nature. The only straight lines we have are in muscle. And muscle is notoriously weak. If you try and load muscle outside of its plane of contraction, it will fall apart. If you take the fascial bag away from a muscle, if you just peel the fascia away and you separate it out, it just disintegrates. Muscle relies entirely for its integrity on the fascia that surrounds it. And so therefore the muscle is proteinaceous pink paste. It's not connective tissue. It just disappears underneath your fingers. And so it's the bags that give it the container, the bags of connective tissue that allow hydration to run through it, allow fluid to run through it. The heart is pumping out blood and nutrients in the form of oxygen, but it's the fascia that's keeping it open, that's keeping the construct of it and allowing movement to go through it. Can you get fascial buildups? I think you probably can. I've seen them. Can you release them with your hands? Yeah, I don't know. Jury's out on that as far as I'm concerned. You know, the things we can do with our hands probably aren't the things we think we can do with our hands. But, you know, I've only been doing it with my hands for 30 years, so I haven't got really a clue what we're doing. Now, I want to warn you about this next slide. I am not an artist, right? My artistic skills are that of a 4-year-old with a potato print, right? But I was trying to find a slide that demonstrated what I was trying to get at, and I couldn't find one. So I did the disastrous thing of getting a pencil out and a piece of paper and trying to draw it. This is Mummy. And again, I'm just going to come out of this and just change the slide a little bit so that you can see it a bit better. So there we go. That's my little tree, and I've annotated it. Figure what? Hamstrings. The ischial retinaculum. This is what I'm going to call the ischial retinaculum. This bit in here, and gluteus maximus, and then sort of the rest, if you like. Who's laughing? I want a sticker for that. Can I go and get a sticker? Yeah. Good boy. I want somebody to take that home and put it on their fridge. The point I'm trying to get at is I'm trying to look at the distribution and load and distribution of load. And wherever we have that distribution of load, we have it a lot more spiral and circular than we have in straight lines. So wherever you find a straight line, it's always going to be going off. It's always going to be curving. It's always going to be moving around in rotation. We are rotational in our movement. We are rotational in our fluid movement. Fluid moves in a spiral. Everything is in spirals and movements. And the tendency for us as humans is to try and sort of make things linear, to try and make straight lines of things. And it's a big mistake, and it's a big mistake when we try to think about therapeutic intervention as well, because again, we go into straight lines, and we go into linear, polarized positions, on or off. And it's not useful thinking. There is lots of positions between on or off. What I want to do is just very, very quickly show you a little video of how I try to replicate the Perez-Bulment paper in my own clumsy, dissective way.
We can see that there isn't a huge layer of deep fascia over the glute maximus, but that there's a sort of an aponeurosis. This is the crest of the ilium, and then this is the gluteus medius, and this is sort of an aponeurotic sheet, quite a distinctive aponeurotic sheet that sits across the gluteus medius. So sometimes the superficial fascia comes away from the deep fascia quite easily, but in this instance it's not as straightforward as it seems. But it's really, really important to remember that this is all iliotibial band, that there is no thing in the leg that we can call an iliotibial band. It just does not exist. So I'd have to make an iliotibial band from here in order for there to be one. There we go. There's our tissue structure that we would refer to as the fascia lata. What I want to do now is I want to sort of separate and start to tease out a little bit these tissues, and I want to follow a filmy line wherever possible, rather than necessarily following the line of the muscle, which will disturb me. And I can see that glute max is pinned down through this line of connective tissue around the ischium. Again, it's pulling through there, so this is going to go round into the pubis, and I'm going to separate that out. So as I separate it, I'm not separating it along any lines except, see this sort of filmy tissues, I'm sort of using blunt dissection, which is with my fingers, and then also I'm not cutting through any muscle here. There's no muscle being cut as I make this separation. This is all connective tissue. See that sliding surface there? So I'm cutting through connective tissue as we go, and it's the connective tissue which is the tethering element of gluteus maximus. This is all still gluteus maximus, it's all still integrity. I've got no muscle which I'm cutting through here, and this is following the line of what will be the sacrotuberous ligament eventually. So what we can start to see from here is, if I sort of peel this back a little bit, is we can start to see this is our fascia of the gluteus maximus on its anterior portion of it, and it's pinned and it's stuck across what will be effectively a retinacular type tissue over the head of the hamstrings. Now, because I've unpinned it, now we've still got the integrity of the fascia lata bag, and if I just start to sort of tease some of this retinacular away, and that's our sciatic nerve into there, we get the idea, we get the understanding of how much of a connective tissue structure is embedded in the back of the legs, pinning down the glute maximus to the head of the hamstring. That's a gluteal artery.
So Perez Bullman did it way better than I did in terms of the ability to do transverse cuts and all that kind of stuff. And so I didn't have that ability. It's just me in a lab in Poland. That's an hour and a half it took me to do that, the whole thing and down the leg as well. So, but the idea here of this is that we have to consider these as conjoined structures, as functionally conjoined structures. And I want to show you effectively what happens now. So I'm going to show you, this is bonkers. I just came across this in terms of, well, what do people do when they talk about firing of the glute? So again, the idea of firing of the glute. Now, glute doesn't have a huge number of motor units. It doesn't have as many, say, as gastrocnemius. So potentially there is a stabilization element rather than necessarily a massive power element. So even though it's a big muscle, does it have power? Does it have driving power? And the answer is not probably as much as we think. So the idea for glute is therefore seeming to me to be, and there's an aponeurosis that comes above it into the external oblique as well, but it seems to me to be a stabilization factor. And pretty much everybody that I've ever seen with back pain, knee pain, lower limb pain, anything like that, is unable to use the full range of their glute as far as contractility is concerned. And so I've done this a couple of hundred times, and people look at you and then they sort of look at you strangely, and I never ask anybody after a session, is the pain gone, do they feel better? I ask, is anything different? You know, when people walk out, it annoys me when people work on me, they go, oh, you feel better, is your pain gone? And I've had it for 40 years, come back in 6 sessions and 100 quid's time, 500 quid's time. But I want to know if anything's different. And remembering also that pain is an output. Pain is a brain output, not an input. You know, the whole idea of nociception is there, but it's a case of when it gets to the brain. It's one man's pain is another man's pleasure. So you just do not know. Pain is an output. It's a signal that we get that we then interpret. It's not necessarily something that exists independent of the individual. So if we understand that, we can also understand that once the input changes, the output can change as well. It really is as straightforward as that. So I'm just going to press, just so I know where I am on time. Can I just borrow somebody's buttocks? Not the rest of you, just anybody particularly that's been wandering around today that's got any kind of lower back aching, more so aching than pain. I'm not dealing with any subluxations or any kind of structural deficiencies or something like that. Thank you. Could I just borrow you up here a second? I'm going to be touching you on your bottom. So just so you know, she's still coming though. She's still it's not too late to turn around. Thank you very much. That's very brave. Come on, give her a hand. Thank you. Great. So come on up here. Thank you very much. I don't know if you can hear me, well, because this thing doesn't work. What's your name, sorry? Charlotte. Charlotte, do you have pain, discomfort, anything going on? Okay. Is it aching more than anything else?
Aching more.
All right, okay. So the idea of this, and you can try this on yourself, it's very, very straightforward. The idea of this is to, I'm going to put this down here. This is very undignified. Is I'm going to ask Charlotte to just contract, okay, whoa, just wait a minute, she's keen. I'm just asking her to slowly contract. I want you to really, really slowly, so, too quick. I want you to slowly, I want you to, like a dimmer switch, there we go, thank you very much. Slowly, really build that slowly, slowly, slowly. So what happens is I'm asking her to contract and her immediate go-to is boom, on. But I don't want it on, I want it on a little bit. Then it's like an animation. I want like a dimmer switch to go from dark to light, almost imperceptibly. And it's very, very hard to do that. So the range isn't quite there on Charlotte's glute. All right, so again, slowly, 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 build. Whenever you're ready, in your own time, off you go. 3, 2, 1. Oh, there we go. And now we're on again. Can you feel what's happening? Yeah. Okay, so I want you to try and build it slowly, 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 slowly. That's it. There we go. All the way. There we go. Keep going. That's better. All the way, all the way, all the way. Keep going. And it's going up in these sort of jerky increments all the way to maximum fire. At the end, now she's got fantastic glutes at the end of that range. It's just between off and on. There ain't much. And now it goes. Boom. It collapses. You know, like an asthmatic pensioner. So Let's build that up again, please, Charlotte. You're just wasting my time, your time, not mine. That's it, all the way, at the end, that's it. All right, now slowly let it go off. And boom, it goes off again. Okay, so I want you to bring it back on again, all the way on. Okay, now slowly off, slowly off, concentrate. You can do this. She can't do this. Okay, you're not. There we go, that's better. Okay, now slowly but surely. So what we'll do is we'll do this a couple of times. Keep going, Charlotte. And again, push back against my fingers. Push fingers away. All the way, hold it there. All right, now slowly, slowly, slowly let it go. Can you see how it's going in increments? And what I want it to do is I want a smooth movement all the way up and a smooth movement all the way down. And it's going to take a little while with Charlotte. Yep. Talk amongst yourselves. So, all right, and it will take a while for all of you. Anybody that has any kind of dysfunction or any pain, any discomfort, any loading, and these are people that may well have massively flexible hamstrings. They may be able to put their face on the floor. Good luck to them. I don't know why they would, but they would. You know, this idea that flexibility is good for you, some mythical idea that stretching is a great thing and that flexibility is marvelous. I don't know where it came from, but it's not a healthy or useful model, particularly if you're unstable. If you're unstable and you're flexible, then stop being so flexible and be more stable. It's not rocket science, is it? That's it. Now she's getting there. All right, thank you very much. Just have a walk around over there for me and come back. So go over there. Fetch. Come back. I'm just looking for change in position, in location. Is the aching different? Is it worse? Is it moved around in any way, shape or form? It's not as uncomfortable. So you just go and do that yourself a few times, and what you'll find is that what you've done is you've basically allowed your glute to operate through its full range. It's a massive function. Thank you, Charlotte, very much. Thank you very much. And I do it bilaterally, always do it both sides, always do it both sides. So it's a massive muscle, but it doesn't ever operate through its full range. And if it's not operating through its full range, it's not stabilizing you through its full range either. So you're able to turn it on, you're able to turn it off, but you're not functional in its full capacity. That's it. And I've seen years of back pain just switch themselves off because it's an output. There's nothing inherently wrong with anybody. They haven't got any dysfunction. Most back pain doesn't have any dysfunction. Most pain doesn't have any, back pain doesn't have any pathology. It's just basically, it's just a bit tired. So that's it really. By the way, so I know it's a bit of an anticlimax, but but by the way, so this also works in terms of things like knee pain. It works in terms of things like, you know, tight hamstrings, whatever they may be. So you might find that actually loading and strengthening and getting better function gives you better range of movement. This is the idea that it's only stretching is going to give you better range. Not the case. Especially if you look at A.L. Lederman's work, he's talking about loading, eccentric and concentric loading through a full range, strengthening. Your muscle doesn't want to move for its full range because it's not strong enough to do that, so therefore it hurts. Stretching isn't going to help that. You know, so this is a kind of functioning, a kind of resistance. You can do it on yourself, just grab hold of, don't do it at the bus stop, you know, just people just and feel what you can do. You'll feel that it goes on and it goes all the way off. And once you've mastered this yourself, teach your clients. Just experiment with it. I'm not saying somebody comes in, they've got back pain, you do this and send them home. You know, you can still lie them down and give them a treatment and charge them for it, but you'll be surprised how many people go, oh, the back pain's gone. You know, pregnancy, fantastic for pregnant women with back pain. It's just bonkers. But if you think about it, it's logical, it makes sense, it's very straightforward. My thinking is in therapy, and I've been in this business for 30 years, is we do too much, we press too hard, and we do it because it makes us feel better, not because the client needs it. That's my summing up of 30 years of manual therapy, sorry, but you know, the chances are we could probably get away with about 90% less than we do and get the same effects, but try charging for that. Yeah, kind of a sticker, yeah. Any questions about this? Or anything else? Price of fish in Latvia, I don't know. Any questions? Anything about the glute? Anything about dissection? Yes. Yes. Can I do this with other muscles as well? I would imagine so, but I've only ever done it with the glute area. I haven't really tried it with other areas as well. Now, there's other things to consider in terms of getting the knee slightly soft and making sure people are in the right position. It was just quite a rushed job to show Charlotte there, but I would imagine that the same principle would apply with resistance to it. So play with it, absolutely. You know, there's a lot of good logic to suggest that if you move something through its full range, it's like you see people doing something at the gym. They do that. It's a very limited movement. If you get yourself an over-the-door, what do you call it, the TRX type thing, the suspension trainer, and you move through your full range, you're still doing the same loading, but you're actually loading through your full range. Are you going to be fitter and stronger than that? Well, I would suggest that unless the job that you are doing just involves that or that, then yeah, you know, get all the ranges that you can. That's what we're after. What's our ability to move is ability to move through all our ranges functionally, not just into a narrow range. Mm-hmm. Thank you for your question. Any other questions at all? So thank you very much. We run dissections all over the world, really. Colorado next year, and Poland, and Cork. Cork should be great. We're going to drink a lot in Cork. So come to those. And it would be great to see you. If you have any questions, then please feel free to email me or contact me. Thank you very much for listening. It's free drink time. Woo! Thank you.